physician collaboration, and both are governing bodies, midwives, the American College of Nurse Midwives, ACOG, the American College of Gynecologists. They both agree that women's health care is most effective when it occurs in a system that facilitates communication among providers. I don't think there's a better statement out there that could describe and bring the care that Dr. James provides to the women of Orange County, and we are really lucky to work with him as well as our other collaborating physicians in this practice. My name is Cam Tuttle. A little bit about me. I have been a working midwife for 2 years. I was a labor and delivery nurse prior for 5 years, and I have grown into the Hoag system since day one. Being a nurse at labor and delivery in the Newport Beach Hospital was actually my first nursing job. I've never looked back. Labor and delivery has really been the only thing I've ever wanted to do with my life. So to start our presentation, I'll go ahead and go through our objectives. We hope to give you a background and define physiologic birth. We will describe the benefits of physiologic birth. We'll define the role of midwives, doulas, and physicians. And we will also discuss the ways to achieve physiologic birth. So the background of midwives and physiologic birth. So I like to add this slide in here because I do really feel history matters. And being a working midwife, I often reflect actually on the history of midwifery in understanding it better myself and also educating my patients and fellow colleagues and physicians. So midwifery care actually didn't become medically recognized in the US until about 1925. Up until then, midwives actually were the leaders of all things birth. Birth used to be a home-centric, socio-involved community event of a woman's life cycle, and it does speak true to kind of that concept of having a village of women who commonly come together and support one another through this vulnerable yet incredible transformative event. So as hospitals became more popularized and health insurance accessibility arose, they basically brought women out of the homes into hospital care centers, and also with the intention of increasing infant and maternal morbidity and mortality, and increasing just better outcomes was the goal. So what had happened is in the 1960s and beyond, when this was kind of happening, women started to become more demanding of having more control of their body and actually a less medical focused birth experience after having dissatisfactory experiences in the hospital setting. So that brings us to the 1970s, and that's where we found the birth center movement. Birth centers were kind of visualized as being this happy medium between having readily accessible care and also having really well-trained providers, nurse midwives, at the center, and again, bringing that holistic approach to women's health care with a collaborative physician treatment plan. In 1996, we have the World Health Organization who actually started reflecting on research and literature and called for an elimination of unnecessary intervention in childbirth, which included kind of the call of more midwives and bringing and seeing how we can get midwives back to the hospital setting. And here we are now in the 21st century. I think collectively all providers, both obstetricians, gynecologists, midwives, and even more so chiropractors, pelvic floor therapists, anyone involved in women's healthcare, especially coming to pregnancy, labor, and birth, we do all have the mission of providing and supporting human childbearing physiology and to avoid the overuse of interventions. Ultimately, this achieves us better health care. More options means better women's health care. I'm going to go ahead and pass it along to one of my colleagues, Melissa. She's going to go ahead and get us started at defining physiologic birth.
Hi, sorry. I guess we had some technical difficulties. So, my name's Melissa Alexander. I'm one of the certified nurse midwives at Orange Coast Women's Medical Group. I've been here for about 5 years. And before that, I was a labor and delivery nurse. I graduated nursing school in 2004. So, I've always worked in the hospital, either postpartum, antepartum, labor and delivery. So, childbirth and women's health have always been my passion. So I'm tasked today with defining physiologic birth. So the definition is normal physiologic labor and birth is one that's powered by the innate human capacity of the woman and fetus. And that is a picture of our birthing tubs that we have at Hoag Irvine for laboring, but not for delivering in. So the characteristics of physiologic birth is spontaneous onset and progression of labor where everything kind of works together. So you have these biological, psychological conditions that promote effective labor. And the goal is to have just a vaginal birth of the baby and a vaginal birth of the placenta with minimal interventions and hopefully without any interventions. You also want to see a normal blood loss, so physiologic blood loss, and we have certain measures for what's normal blood loss and what's considered a hemorrhage, and so we're very well trained to watch for those and give medications as needed, but the goal is always to not give them and just kind of let your body do what it's meant to do. And then you want to have an optimal newborn transition period through skin-to-skin contact and not separate mom and baby to facilitate that and to help with early initiation of breastfeeding. And so some of the things we're trying to avoid, this picture I suspect is somebody that's in an operating room giving birth for probably they have some complications. So high risk situation that is really not a part of physiologic birth. So we want to try to avoid induction or augmentation of labor, an environment that's not supportive to your needs. We want to make sure that you're heard and listened to, your wishes are met. You want to have some time, not have time constraints, but allow your body to do what it's meant to do. And so we're not going to be sitting there and saying, okay, it's been 24 hours. We have to have a C-section because there's really not a clock on it. There's a lot of things we look at. We also want to avoid nutritional deprivation, so we allow eating and drinking in labor. Most women who are seeking physiologic birth are trying to protect and prevent themselves from getting any kind of opiates or analgesia, meaning like a epidural or spinal, and then avoiding an operative vaginal birth like forceps or vacuum, and then avoiding a C-section. And something else to avoid is immediate cord clamping. So we like to do delayed cord clamping until the pulsations actually stop. So we have our finger on the pulse of the umbilical cord and wait till that cord is nice and white and we're not feeling any more blood pulsing through it. And then we want to avoid separation of mom and infant, again, because that'll really help with breastfeeding. So we want to really avoid any situation in which mom feels threatened or unsupported. So why pursue physiologic birth? Well, kind of for all the reasons I mentioned, but then also women tend to feel like really strong physically and emotionally after they give birth and helps with motherhood. So here's a lot of the benefits. Less postpartum pain, a quicker recovery physically from birth, an increase in self-esteem. So one of the things I remember from midwifery school is one of the midwives saying how after giving birth, when just watching women across the board give birth, after an unmedicated birth and having that baby brought to their skin, the first thing they always say is, "I did it." So that's like very empowering to feel that. And then you can have that enhanced bonding with the baby, doing skin to skin and feeling really connected with your baby after a birth like this. So that can reduce the likelihood of postpartum depression, make the baby calmer, more settled, enhance breastfeeding, and cause that skin to skin and breastfeeding and that bonding time can help with a positive respiratory transition for the baby. And just a vaginal birth in general can help with the gut colonization for the baby. And then some of the benefits to the baby, in addition to that gut colonization, is reduced likelihood of any risks associated with medical intervention, improved bonding again, and then higher probability of breastfeeding. And to society, there's great benefits to normal physiologic birth. One of them's reducing out-of-pocket costs, which is great, and then just helping people feel supported and involved in decision-making, informed choice, informed consent. And when you have successful breastfeeding, then you have less risk of chronic diseases for the baby, and then reduced, complications from surgeries if you're needing a C-section or kind of vaginal operative birth. So those are things that we're avoiding and can hopefully help. And I'm going to pass it on to Mallory now.
Hi, my name is Mallory Monroe. I'm another certified nurse midwife at Orange Coast Women's Medical Group. I've been working in the childbirth area, prenatal, labor and delivery, postpartum for the past 11 years. It's been my passion of my life. My first experience with birth was physiologic birth. I was able to work in another country in a rural area, attending out of hospital birth for my first introduction to what birth can look like. And that really shaped who I am as a midwife and what I believe about birth. And it was really important for me to be able to see how birth looks like undisturbed. And that's really what we're talking about here today. So I want to explain a little bit more about this birth team. So we have doulas, midwives, and OBGYNs. And that's a really common question that we get. Even some of my friends and family often think that I'm a doula. It's just, these are, unless you're in this world, some words that maybe people are not familiar with. In addition to this team, we also work with labor and delivery nurses, and part of your birth team will likely be your partner or maybe your mom. But an important difference, doulas are non-medical labor support providers. They often also provide support prenatally and postpartum. Their role is to provide emotional and physical support, advice, potentially, especially when it comes to ways to cope better with labor. They are often helping you build your birth preference list or your birth plan, and helping make sure that those things are respected and carried out as much as possible during the birth process. They are comfortable being around women in labor, which can be very supportive during that birth process. And oftentimes, we as midwives are really hoping to be able to also be around during your birth, providing that labor support. But in case we are attending to another woman in labor, we like to have that doula who is really dedicated to providing that labor support, so that you have that type of care constantly during your labor. And us as midwives, we are, especially certified nurse midwives, we are first registered nurses who have gone to more schooling to become midwives. We are medically trained, and we are providing the medical care for low-risk women with uncomplicated births. We're definitely trained in treating emergencies and a variety of complications, and then we will defer and consult with our number 3, our MDs, our OBGYNs, when labors become or pregnancies become complicated, and use them as our backup system and our consultants and our teammates. We love our OBGYNs. They're super supportive of us midwives in this practice, and they're great to utilize when complications arise. So helping prepare for a physiologic birth, we can't control all the variables, but there are certain things we can control, and certainly in your prenatal care, your midwives will be helping guide you through helping control the things that you can for an optimal healthy pregnancy and healthy birth. Exercise and nutrition is definitely key. Staying active during your during your pregnancy and making healthy choices, helping you gain appropriate amount of weight, and helping babies optimal nutrition is definitely key. Tapping into your emotional wellness and considering addressing some underlying issues if there's anything going on. There are so many factors when it comes to birth. It's not just a physical process. It's absolutely a mental and emotional process as well. And so identifying those things and addressing them early can be really helpful. Childbirth education is huge. We really encourage childbirth education. Having a baby unmedicated, especially your first baby, is definitely a large task and absolutely doable, but it is super important to gain that education in your pregnancy. Experiencing the discomforts of labor is very unnerving and can be scary if you've never prepared for it. And the only times in our lives that we experience pain other than, childbirth, it's associated with something that's wrong that's happening to our body. Being able to flip that script in your mind to understand that the increase in discomfort, the increase in intensity is bringing baby closer. These are all really important things to learn and shape your body. If we have a fear response to the experience of labor, this can actually work against us and cause labor to stall. And there are physiologic responses to fear, that fight or flight response, that can actually block our natural oxytocin, which can stall out labor. And so preparing before with childbirth education can actually lead to a more rapid and effective birth. Consider hiring a doula for all the reasons I expressed earlier about how wonderful doulas are and the support they can provide. And then developing a birth plan with your doula and with your midwives or with your doctor is definitely helpful. We like to call it a birth preference list because we can't really plan for birth. Birth happens different for every single woman, and there's lots of different variables that can occur. But our goal is to try to maintain as much of your birth preferences as possible, and hopefully all of it. And that's why we like to just sort of frame it that way. And then establish a trusting relationship with your provider. We have 6 midwives in our practice, and we love for you to meet us all. And so throughout your prenatal care, you meet all of the midwives, and we have 30-minute visits most of the time, sometimes a little bit shorter if we're a little bit busy, but we try to really sit down and get to know you as a person, and we would like you to get to know us too, so that we have that back and forth relationship when it comes time for your birth. You'll really know and trust the person whose hands you're in. And then a comfortable environment from the start. We don't just like to set our rooms up pretty because we think it's cute. I mean, we do think it's cute too, but we really believe that the environment that you're in sets the tone. It causes your whole body to relax. If you feel mentally and physically and emotionally comfortable, that changes the whole mood. We don't want everything to feel so clinical. We do not believe that pregnancy is a disease. We want to just meet you in a comfortable place, talk about how your pregnancy is going. We absolutely, can address anything if they have complications that arise, but we want to treat your pregnancy as a part of your life cycle, not as this horrible thing that's happening to you. And then a comfortable environment for your birth. We have beautiful rooms at Hogue Irvine. 2 of them are midwife suites. The rest of the rooms we are super happy to use, almost like midwife suites. The only difference, they just don't have a queen size bed. They have a regular hospital labor and delivery bed, but they can all have tubs and utilize all of the same beautiful resources as our midwife suites. But we encourage our patients to stay at home for as long as possible in early labor. We would like our patients to arrive to the hospital in active labor if that's the right call for them, if that's safe. And we would talk you through that process. And so that the active part of labor, transition, and the birth of the baby is all happening at the hospital. We have a very supportive environment. Our nursing staff is super supportive of us as well, helping keeping the room quiet and the lights dim. And we try to reserve medical interventions only as needed. We try to avoid routine interventions and talk you through every single intervention if it's needed, and talk you through the risks and benefits. And ultimately, these things are your decision. We only are recommending things that we think are the most safe for you and baby. So different coping techniques for labor, continuous labor support by a doula, your partner. We can provide this kind of support at times, doing hip squeezes, counter pressure. We have tons of tricks. Doulas are fabulous. They know so many things. And just mental coping skills. Sometimes finding that mental space in your head, that focal point, is hugely helpful for coping with labor. And then childbirth education is really key to helping with that mental aspect, preparing ahead of time is really key. I like to tell women that we know that you are very physically capable of having an unmedicated birth. If we didn't have anesthesia, that's what we would all be doing. That's what we all used to do. It's not a question of whether or not you can physically cope with the labor. It's a mental game. And so preparing mentally for birth is really important. That's why Bradley or Hypno Babies or Lamaze, those are all wonderful options for preparing ahead of time. And then some non-pharmacologic pain relief measures. We have our tubs that are fabulous. We also have showers that have a rain shower or a handle that you can hold to put it in a more specific spot if you're needing it on your back or on your belly. Relaxation, massage, acupressure. These are all great things. TENS machines, aromatherapy, music. We love all of these. They also just set the mood, which can help with your mental state to maintain those focal points. And then if needed, we can utilize medications, including nitrous oxide, IV narcotics, and epidurals. In our practice, we're not pro or anti-epidural. We're certainly pro physiologic birth, and we really encourage our patients who are seeking that to go for it. We do not feel like it's a failure to utilize medications in labor if that's what's needed for your birth. And we will absolutely provide that for you if that's what you're requesting. But our goal, if your goal is to have an unmedicated physiologic birth, is to get you there. But we will not withhold anything from you if that's what you're wanting in the moment. So physiologic pushing and immediate postpartum period. We like to wait for women to feel the urge to push before we encourage pushing to happen. And we push in a variety of positions. The beauty of having an unmedicated birth is that you can be in really whatever position you want in any part of the room that you want when it comes time to push your baby out. We catch babies on the toilet, in the shower, in the corner of the room, on the ground. Wherever you are, we come there and we bring our tools to you. There are so many positions that feel good for some women, and we're happy to be there and provide that care for you safely. Some women are not sure what position feels good, so we're happy to suggest different positions for you as well. And the immediate postpartum period, we like the baby to be skin to skin, so that bonding can happen immediately. We know there's so many good benefits of uninterrupted skin to skin for that golden hour. Baby's blood sugar is more regulated. They transition easier. They're able to breathe more easily when they're first learning to breathe, those first breaths. There's so many great benefits. Breastfeeding is initiated easier. We can also provide that delayed cord clamping during that time. And then we allow for physiologic birth of the placenta. And so the placenta comes when the placenta is ready, unless there's any kind of indication that that would be, maybe there's a concern with bleeding. Otherwise, the placenta comes naturally, and then that golden hour of bonding with the baby and your partner. And here's another picture of the Hogue Fudge Family Birth Suites. This is actually a room. This is not a midwife room. You can see that it's a normal hospital bed, not a queen size bed. And you can see they're still fabulous. All of our rooms are really great, and they're brand new. 2 out of the 12 have the queen size bed. We can do aromatherapy in any of the rooms, labor tubs, and the rain showers, like I said, with the wonderful nurses that are very experienced in supporting physiologic birth. We are utilizing our midwifery model of care, letting you lead, and access to epidurals as needed, which is one of the great things about having a baby at Hogue Irvine. I really feel like it's the best of both worlds. We can have a birth that would look very much like having a baby at home with very little intervention, but every safety net needed. There's 24 access to OBGYNs, neonatologists, the OR, and anesthesiologists. So if it was decided that it was a better birth plan for you to utilize an epidural, we don't have to, get in the car and go to another facility. The anesthesiologist can come to us, and we can access that if that's needed. And in case of any true emergencies, we have all the best care right there. All right, and we're going to move on to some questions.
All right, so the three of us are here all together to go over some questions that you guys wrote in. Thanks so much again for being here and writing in. We love going through the education and just describing the care that we can provide to you and your baby. So we also wanted to take this moment too to just let you guys know that we do have some social platforms where we also give out some education and just share birth stories amongst previous patients, of course those with provided consent and who would like to share. So you can see birth and what it could look like for you at the Hoag Hospital Irvine Fudge Family Birthing Suites. I would like to say too, as we answer questions, that this is particular to the Hoag Irvine campus. We are in no way speaking on behalf of the Hoag Newport campus. And that's our little Instagram handle right there too. So the first question I have is, if we want an epidural, is labor delivery on our back the only option? Kind of touching on what Mal just ended us with, if you did plan and decide that an epidural was going to be the best option for you to feel that you had a positive and empowering birth experience, the Midwives of Orange Coast would of course support you in that, and Hoag Irvine has the accessibility for that. Laboring on your back is actually not really recommended when you have an epidural during labor. And for birthing, we can utilize different positions even with an epidural. We have some of the top anesthesiologists, I feel like, at our access at Hoag Irvine, and the epidurals they give aren't necessarily dense and don't allow you not to move. It's the understanding that you can't get out of the bed and walk with an epidural, but that allows us to be able to birth on our side, and we've even been trained with epidurals to allow you to birth your baby on your hands and knees. So it just kind of comes down to how your body responds to the epidural and what you're capable of doing movement-wise, but you will be in the bed if you do have an epidural. And the second question, and then I'll pass it along to Melissa. What is the updated admission procedure at Hoag for labor and delivery? Again, I'm just touching on Hoag Irvine. As far as I know, the updated procedures that took place back in March still stand, but again, with an evolving pandemic, we also evolve our admission policies as appropriate. Right now, we do routinely on admission for the laboring person, we'll test them for COVID. That is an antigen test. It takes about 30 to 60 minutes to result. We do ask and hope that you would understand that wearing a mask is really important to decreasing exposure to all the laboring, birthing people around you and babies and staff caring for you. So until your COVID test is negative, you will be required to wear your mask. After the COVID test results negative, you can then therefore remove your mask and continue to labor and birth without a mask. We do ask that your support person, your primary support person, usually the partner, does wear a mask, and that would continue throughout the labor and birth as well. Hoag Irvine now also allows a secondary support person. This is someone that can be with you during labor, birth, and overnight. And that is also with the with the expectation that they're following the state mandate, meaning providing us a negative COVID test within 72 hours or proof of vaccination upon entrance. I know sometimes a lot of us are like, well, how can we get those tests the day of? And a lot of us encourage and know of clinics nearby, whereas you start laboring at home, and given it's your first baby usually, you have ample opportunity to go ahead and have your loved ones get a quick COVID test at the multiple clinics. There's one also right across the street from Hoag Irvine. So that's what we've seen work really well for our patients, and we haven't had issues thus far. And again, the doula is also seen as a support person and someone along the healthcare team. So we actually at Hoag Irvine are allowing and very happily allowing doulas to come and support our patients 24/7, given that they can provide a proof of vaccine or a negative COVID test within 72 hours. So that is 3 people total.
Okay, so one of the questions I had was, are midwives a part of Hoag's standard labor and delivery team? Or if we want a midwife, we need to find our own and bring them. So the 6 of us are with Orange Coast Women's Medical Group, and then we have privileges at Hoag Irvine, so we're on medical staff. So if you wanted a midwife, you can't just show up at the hospital and one of us wouldn't necessarily be there. You would have to actually be a patient with our practice. So you would need to call the office to schedule an appointment. And our office number is 949-829-5500. So, and then if you're with another practice and you're transferring care, we review records before you come in to make sure it would be appropriate. And then the other question I have is, what would warrant an induction for patients under the midwife's care? So we all love and support physiologic birth, but we do recognize when sometimes an induction is needed. Usually, it's typically for a medical reason. Very rarely do our patients need or want what's called an elective induction, where they're choosing to have one without a medical reason. So some reasons for that over the years were like a husband's being deployed overseas and wants to be there for the birth of the baby, and the woman's like 39 weeks, and that would be an appropriate quote unquote elective induction. Some medical reasons would be somebody with high blood pressure, somebody with diabetes requiring induction. There's quite a few reasons, and not everybody risks out of midwifery care just because there's a complication with pregnancy. So we definitely consult and collaborate with our physicians, and we follow the recommendation of the high-risk pregnancy specialist. So we would still be able to work with most women and be with them for an induction. So we try to avoid it, but sometimes it has to be done. Sometimes it's safer for mom and baby for the patient to have the baby. So hopefully that answered the question.
I have a question here. Will Hoag be seeking licensing to birth in the tub? I can't speak necessarily for the higher ups at Hoag. I don't believe that's in the works right now. Right now, we utilize our tubs as a labor support measure and are birthing pretty much anywhere other than the tubs. We don't know if that's something that will come in the future, but we're not planning on that anytime soon. So I think the answer to that would be no.
Okay, I'm going to jump in really quick. A question I get a lot is people thinking they can't be in the tub if their water's broken, and you can be. Absolutely, you can be in the tub if your water's broken.
Good comment. All right, another question that I have here is, am I able to give physiologic birth after delivery via cesarean? And the answer is yes. That is called a VBAC, which is an acronym for vaginal birth after cesarean. And we have lots of women in our practice that are seeking that type of birth. There are different reasons why women have a C-section in the first place. And so we talk to every woman and treat every woman as an individual and talk through their case. And there was some benefits of having a repeat C-section versus seeking a vaginal birth after a C-section, and ultimately determining if that's a good idea to pursue that. And it's up to the woman if she feels like that would be a positive thing for her and it is a safe choice. And it often is for a lot of women. Depends on the circumstances, but in many cases, it is a very safe option.
All right, these questions are flowing. Let me go ahead and grab the next couple here. Do you want to divvy this off? All right, the next one I have is, do you support and will work with moms trying for a VBAC? The answer is yes, absolutely. We most definitely support our moms on the path for achieving a VBAC. And like Mallory said, most women are good candidates for VBAC. There are some circumstances where we, of course, will counsel, and a lot of the times even use our collaborating physicians to counsel our patients on the statistic chances of having a successful VBAC and making sure that that's safe for the laboring woman. But very rarely is someone absolutely not a candidate. And of course, at the end of the day, both the midwives and the collaborating physicians do support an attempt trial of labor after cesarean. If that becomes a co-management situation, we can always do that, but most of the time we independently can help manage and support your VBAC in labor. And we do require prenatally that you get a consult with one of our amazing physicians in the practice to go over those risks further with you. And then you, of course, would just continue on with midwifery care. So
I have a question here about, is dad able to quote unquote catch the baby. So absolutely, we like to have our dads, if they're interested, help catch. Usually, if I can't speak for the other midwives, especially the ones that aren't here, but what I typically will do is kind of help control the delivery or the birth of the baby's head to protect the perineum from any vaginal tearing, and then kind of have the dad come be right with me delivering the rest of the baby, and then passing baby off to mom. And then doing the delayed cord clamping and the skin to skin, and then having dad help having dad cut the cord. So I actually will always ask, do you want to help catch the baby? I think most of us do.
Yeah.
So then I have a couple, I think probably just like policy and COVID questions. So if dad leaves, can they re-enter, such as getting food after birth? And yes, they can. They get a bracelet so they can come and go freely.
As long as they do a state mandate.
Yeah, as long as they follow the state mandate rules. So what are the rules for unvaccinated, and specifically meaning, again, for COVID, for mothers, so I assume for the birthing woman. So there's not any really rules. It's pretty much the same as it is for everybody, vaccinated or not. You come into the hospital, wear a mask until you have that negative COVID test. So no mandatory vaccines or anything like that.
And the question I have here is, how long do we have to remain in the hospital before being discharged? And for mothers, we are in charge of the discharge process as the midwives. And normally in an uncomplicated vaginal birth, moms are safe to go home relatively quickly after a vaginal birth, within half a day even. But the standard care is to stay for at least 24 hours and sometimes longer, which is really to care for the baby. And the pediatrician will dictate the discharge of the newborn. And there's things that are checked around 24 hours of life. And if everything looks great, that's most commonly when moms and their baby will go home. Sometimes 48 hours is warranted if the baby needs a little extra care. After a cesarean section, if that's what's needed, usually about 2 to 4 days, depending on how fast recovery is the average stay. And then I have a question here. Am I able to labor IV free? And the answer is yes. With the caveat that there are a few times when IVs are needed. There are some medications that are given through the IV that are warranted with certain circumstances. So the answer, yes, sometimes. And sometimes women need IVs too. And then I have, are doulas covered by insurance? And that would be awesome. I have actually heard someone tell me that their insurance covered a doula, which I thought was amazing, but I've only heard that once. So that really depends on your insurance. And most of the time it's not covered, but ask, maybe. Go.
Sure. So I have a layered question here. I will try to read it back as you asked it. When is synthetic oxytocin utilized to induce labor? As part of my birth preferences, I noted no synthetic oxytocin and had an individual then ask me, how will we help you have a baby then? I'd like to start labor naturally. This gave me a pause as to how much intervention might be suggested. So again, we can't completely control the variables of labor and birth and pregnancy. We can't control the variables of the evolution from low risk to high risk. But it sounds like, as far as your question goes, you were looking for an honoring of your birth preferences. And so I would like to say that as midwives, we do go over the birth preference sheet with you throughout your prenatal care, and we even dedicate the usually 36 to 37 week visit to particularly go over this and answer questions like this. And we try our very best to navigate the different journeys your birth may take as far as like asking these specific questions. But at the end of the day, if synthetic oxytocin is being recommended to you by one of your midwives or by one of your providers, usually that recommendation is coming from a medical necessity standpoint. As midwives, we don't practice synthetic oxytocin administration for reasons that aren't medically necessary. I hope that conveys an answer to your question. And again, we would thoroughly counsel you through the circumstances if that's what was being called for and recommended. And we would explain those risks and benefits and give you full informed consent. And at the end of the day, you can decline. So we really do try to stay true to our belief that we are in this journey with you, walking alongside you. We'll counsel you appropriately and support your decision. If a midwife hasn't arrived, would we be asked to stop pushing? The answer is no. I don't think I have much more to add. If you are feeling an urge to push, and sometimes you really can't fight that urge to push, you just start pushing. In the hospital setting, you have plenty of capable hands to be there and support you and catch your baby. We have a hospitalist that's there 24/7, so a physician is always on site. And the midwives, technically we get quite a bit of heads ups from our patients because we're actively communicating with them when they're laboring early at home. So I don't see that the circumstance happens often. I haven't experienced it myself because usually I'm en route before the patient's even arriving. I don't know if you guys want to add to that. But.
Just call before you come. If you show up and we're not there, then that could be a problem.
But you will have someone to catch your baby.
Yes. Can you take them, please?
Yeah. Okay.
Oops, sorry.
Getting lots.
Oh, so this question is, if not discharged for longer than 24 hours, can existing children visit? Right now with COVID, we are not allowing any visitors under the age of 18. I guess I'm not going to say we, that's just a hospital thing. And I think that most hospitals in the area are still under that policy. So at this time, per COVID, that is not allowed. So sorry.
Yeah. Do you want to go? Okay. If birth results in cesarean section, is the practice open to vaginal seeding? This is a collaborative practice, meaning we thankfully and are happily working alongside world-renowned physicians, and we have to really manage a collaborative relationships. And I would say that both midwives practicing under the board of ACNM and both obstetricians practicing under ACOG, we don't have much literature that supports vaginal seeding thus far. We actively are evidence-based and are open to always seeking literature to help support our practices. But eventually at the end of the day, or ultimately at the end of the day, we don't see vaginal seeding as really having any benefit to the baby. I don't know if you guys want to touch on that, but the recent ACOG article doesn't support it. It's fine. Okay.
Thank you guys for tuning in.
Yeah, and if you all, one last comment. The midwives of Orange Coast Women's Medical Group, we offer free consultation visits. You get to come in and meet one of the awesome midwives here alongside me, and we can take 20 to 30 minutes to discuss with you your current pregnancy, any complications, if you're a good midwife candidate, if it's looking like a right fit for you, and what you're desiring in your birth experience and your birth preferences. So you guys can always call the office and get that set up with one of our awesome schedulers.
Are there experts on site to check for oral restrictions?
Are there what?
Experts on site to check for oral restrictions.
Experts on
tongue ties,
site
maybe?
tongue ties.
We think this question might be about tongue ties. The question is, are there experts on site to check for oral restrictions? And I'm going to guess that's about tongue ties. And we work with our pediatricians a lot for that. We, as midwives, are not resizing any ties, but that's definitely something that you would bring to your pediatrician if that was a concern. They are not doing that in-house at the hospital, but that's a great question.
We also have resources available and referrals for occupational therapists and lactation consultants that can actually evaluate in addition to your pediatrician and give you insight on different oral restricted tongue ties. and whether that would, they would discuss the different routes, whether that's physical therapy or cauterization to correct the tie, if that's something that you're interested in learning about. If this question is specific more to like nutrition during labor and birth and like oral restrictions and that aspect, in a normal physiologic birth, we allow our patients to eat and drink in labor, and we don't require routine maintenance IV fluids, just in case.
Yeah, not sure what the question.
Alrighty, I think we're done. Thank you.
Thank you.